Nerve stimulators. There are two types of nerve stimulators. The one used in regional anesthesia for localization of the nerves, and the other used for monitoring of neuromuscular blockade. Mechanism of action. The electrical energy is provided by a nerve stimulator. There is rise in membrane potential. Threshold potential is exceeded. There is depolarization. Propagation of action potential across the neuromuscular junction, and it leads to muscle contraction. There are five main variables that can be manipulated in order to achieve the depolarization. First is the amplitude of current. Second, duration. Third, frequency of stimulus. Fourth, proximity of the electrode to the nerve. And fifth, polarity of the electrode. Energy delivered is equal to amplitude of the current into duration of the stimulus. Amplitude of the current. Supramaximal stimulus with sufficient current amplitude stimulates 100% of the motor neurons. Duration of the stimulus. For a given amplitude of current, shorter duration will stimulate motor neurons. The duration is 0.1 millisecond. Longer duration will stimulate C fibers, that is pain fibers. The duration is 0.4 millisecond. Polarity. Less energy is needed to stimulate a nerve that is adjacent to the cathode than the one that is adjacent to the anode. Therefore, negative terminal, that is cathode, is connected closest to the target nerve or stimulator needle. Therefore, black electrode, that is negative electrode, is placed distally, and red electrode, that is positive electrode, is placed proximally. Proximity. The relationship between the energy required to depolarize the neuron and distance between the neuron and electrode obeys the inverse square law. Therefore, if the distance is doubled, 4 times energy is required. The elements or electrical components of nerve stimulator. First is power source. Second, constant current generator. Third, oscillator to set the frequency and duration of stimulus. Fourth, display and controls. Fifth, anode and cathode. For regional anesthesia, anode is proximal and the cathode is the one connected to the stimulator needle. For neuromuscular blockade monitoring, there are 2 electrodes. What is rheobase? It is the minimum current amplitude of indefinite duration that results in action potential. Chronexy. It is the minimum time over which the current of amplitude twice the rheobase should flow in order to stimulate an action potential. In types of stimulation pattern, for regional anesthesia, the starting current is 1 milliampere, frequency is 2 Hz, duration is 0.2 millisecond. If too high frequency is used, there is tetany and pain. If too low frequency is used, there is risk of nerve damage. When the nerve stimulator needle is appropriately positioned, when the twitch is elicited by a current of 0.3 to 0.5 milliampere. If higher current is required, that means needle is too far from the nerve. If lower current is required, that is needle is too close to the nerve and there is risk of nerve damage. There should be loss of twitch after injecting 1 ml of local anesthetic, as nerve is pushed away from the needle tip by anesthetic. And there should be minimal resistance to the injection using 20 ml syringe. If there is high resistance or persistence of twitch, it means intraneural positioning. Let's discuss about stimulation pattern of neuromuscular blockade monitor. The neuromuscular blockade monitor is used as a guide for optimal muscle relaxation and time of reversal of neuromuscular blocking agent. The current strength used is 40 to 60 milliampere. The current strength is high due to high skin resistance. A single twitch. It is a single square wave. The duration is 0.1 to 0.2 millisecond. Amplitude begins to fall when more than 70% of acetylcholine receptors are blocked. Train of 4. 4 single twitches are applied at frequency of 2 Hz. That means 4 twitches are applied at the interval of 0.5 seconds. The ratio of amplitude of fourth twitch to the first twitch is sensitive indicator of level of neuromuscular blockade. The number of twitches seen when there are 4, less than 75% of nicotinic acetylcholine receptors are blocked. Number of twitches 3, that means 75% of receptors are blocked. Number of twitches 2, that means 80% of receptors are blocked. Number of twitches 1, that means 90% of receptors are blocked. And 0 twitch means 100% of receptors are blocked. Tetany, double burst, and post-tetanic count are the patterns of stimulation used when there is intense neuromuscular blockade and no visible twitches to the train of force stimulus. Principle: high frequency stimulation of nerves leads to mobilization of presynaptic acetylcholine, which will briefly overcome the neuromuscular blockade and cause visible muscle contraction. Tetanic stimulation: 50 Hz stimulation is applied for 5 seconds. Will cause sustained contraction of the muscle. If neuromuscular blocking agent is present at high concentration at neuromuscular junction, the sustained contraction will fade over period of stimulus. Double burst stimulation: 3 tetanic pulses at 50 Hz, then pause of 750 milliseconds, followed by another 3 pulses at 50 Hz. The fade is better seen with 2 bursts than single tetanic stimulation. Post-tetanic count: this pattern involves a 5-second tetanic stimulation at 50 Hz, followed by a pause of 3 seconds, and then 20 pulses at 1 Hz. The number of twitches that are observed in response to the 20 pulses are counted and can be used to predict how long neuromuscular block will last. Post-tetanic count of 12 to 15 suggests that the return of train of 4 is imminent. Post-tetanic count of 4, roughly 5 minutes before one twitch to be visible on train of 4. Now we'll discuss about the nerves which are used for neuromuscular blockade monitoring. First is ulnar nerve. The location of electrodes is wrist or elbow. Muscle contacted is adductor pollicis and the movement is adduction of thumb. Posterior tibial nerve. The location of electrodes is behind the medial malleolus. Muscle contacted is flexor hallucis brevis. The movement is plantar flexion of the big toe. Third nerve is peroneal nerve. The location is lateral to the neck of fibula and the movement is foot dorsiflexion. Fourth nerve is facial nerve. The location of electrodes near earlobe where the nerve emerges from the stalomastoid foramen. The muscles involved are orbicularis oculi, which leads to eyelid movement, and corrugator supercilii, which leads to eyebrow movement. The difference of neuromuscular blockade in different muscles. Laryngeal and diaphragmatic muscles are more resistant to the effects of neuromuscular blocking drugs. In these muscles, the neuromuscular blockade develops faster, lasts a shorter time, and recovers faster. The reason behind this is greater total blood flow per gram of muscle leads to rapid, rapid equilibration between the plasma and the effect site concentration. The neuromuscular blockade develops slower, lasts longer, and recovers slower in peripheral muscles, for example, adductor pollicis. In facial muscles, the corrugator supercilii follows time course of paralysis and recovery of laryngeal adductor muscles. The orbicularis oculi muscle follows the time course of paralysis and recovery of peripheral muscles like adductor pollicis. Monitoring of facial muscles is poor substitute for monitoring of adductor pollicis muscle. A recent report showed 52% incidence of residual paralysis in recovery room using subjectively assessed eyebrow responses compared with 22% incidence of residual paralysis with hand muscle monitoring. Methods of assessing responses to the stimulation. Placement of electrodes. The depolarizing negative electrode is placed distally, 1 cm proximal to the wrist crease on the radial side of the flexor carpi ulnaris, while another is placed 4 to 5 cm proximally on the volar forearm. Subjective methods like tactile or visual. Quantitative modalities. First is acceleromyography. It is based on Newton's second law. Force is equal to mass into acceleration. Force of muscle contraction is proportional to the acceleration of the muscle. The muscles can be used are adductor pollicis, flexor hallucis longus, orbicularis oculi, and corrugator supercilii. Strength of this modality is it produces continuous record. It analyzes and displays important parameters like train of 4, single twitch, percentage of block. Limitations. It needs pre-use calibration. AMG monitors cannot be used clinically when unencumbered movement of the thumb is not ensured, when the hand is under the drapes. AMG overestimates the extent of top value. Mechanomyography. It is based on measurement of force of muscular contraction in response to the nerve stimulation. The thumb is placed in a holder that is attached to a force transducer. The force of thumb adduction resulting from the ulnar nerve stimulation is recorded and measured. Problem with MMGs are it needs stringent preparation, it needs constant maintenance of preload, and it is very sensitive to repeated stimulation. Kinemyography, KMG. The mechanosensor strip that contains a piezoelectric polymer is placed between the base of thumb and base of index finger. When thumb adducts in response to ulnar nerve stimulation, the polymer strip generates an electrical current that is proportional to the degree of bending. Advantage of KMG is it is simple to use. Problems. The results are not interchangeable with other monitoring technologies. Train of 4 ratio of 0.9 with KMG is equivalent to train of 4 ratio of 0.8 with EMG. With repeated use, mechanosensor strip may slide out of the intended location. And if tape is used to keep the sensor strip in place, it will interfere with the measurement. Electromyography. It measures the electrical event that occurs at the neuromuscular junction. It involves stimulation of peripheral nerve and measurement of muscle action potential. The advantages are less prone to interference from presynaptic or postsynaptic events. It is better indicator of pure neuromuscular function. On repetitive stimulation, EMG is stable over time, decreasing less than 2% per hour during constant stimulation. Temperature affects the EMG amplitude to much lesser extent than it affects MMG. EMG amplitude increases by 2 to 3% for every 1% drop in temperature. Difference between EMG and MMG readings is clinically insignificant. This diagram shows placement of stimulating electrodes 1 and 2 over the ulnar nerve and the recording electrodes 3 and 4 monitoring the abductor digiti minimi contraction. This diagram shows placement of stimulating electrodes on ulnar nerve 1 and 2 and the monitoring of adductor polysis response by the recording electrodes 5 and 6. Common mistakes in neuromuscular monitoring. Not using a neuromuscular monitor. We should use objective monitors than subjective evaluation. Do not administer anticholinergic reversal until train of 4 is 3 and wait at least 15 minutes after the reversal before extubating the trachea. Use of facial muscles for monitoring. It leads to overdosing of muscle relaxant as facial muscles are resistant to the muscle relaxant and potential for direct stimulation of muscle is higher. Using tetanic contraction less than 5 seconds, it gives wrong information. Using subjective evaluation of train of 4 count. The subjective evaluation overestimates the degree of recovery. Determining the onset of neuromuscular block by single twitch at 1 Hz. It falsely indicates the faster onset of block than at laryngeal muscles. Assessing neuromuscular function less than 3 minutes after tetanic contraction. It gives false information due to post-tetanic potentiation. So we have to wait for 3 minutes before subsequent train of 4 or single twitch. Not maintaining monitored muscle normothermia. The cold operating room environment leads to wrong information about depth of the block and degree of recovery. Not ensuring good skin contact. It increases impedance of the electrode-skin interface and there is risk of burn. Therefore, clean the skin before placing the electrodes. Now we'll talk about the terminologies post-tetanic potentiation and fade. Post-tetanic potentiation. There is transient increase in the strength of muscle contraction following a tetanic stimulation is known as post-tetanic potentiation. The mechanism behind is there is increase in intraterminal concentration of calcium. It leads to increase in the mobilization of acetylcholine vesicles and fusion between the vesicles at the motor nerve presynaptic area. So there is transient increase in the end plate potential. It leads to temporary increase in the strength of muscle contraction. Fade phenomena. The reduced strength of muscle contraction after repetitive nerve stimulations, as in train of 4 and tetanic stimulations. The mechanism behind is blockade of presynaptic receptors by neuromuscular blocking agents. It leads to prevention of acetylcholine from being made available to sustain muscle contraction during high frequency stimulation, for example, train of 4 or tetanic stimulation.